Hello, everyone. This is Dr. Andrew Heyman once again. I'm going to be reviewing our final lecture, which is the case review. It's a bit of a long one, but it demonstrates both a typical presentation for a patient. I think the lengthiness of the evaluation process and just gathering information and all the little clues that tend to accumulate the longer you listen to the individual. So bear with me as we go over this. Okay, so this is a 58-year-old white male who presents for initial consultation regarding abrupt onset of gastrointestinal illness on a cruise to the Caribbean. Here's your first clue. He was in normal state of compromised health before embarking, with long-standing fatigue, shortness of breath, cough, joint abnormalities, and cognitive dysfunction. He had abrupt onset of a group of symptoms 2 weeks ago with nausea, retching of bile stained vomitus, watery diarrhea, cough, and itching lasting 2 days. He had worsening of shortness of breath with tachycardia and severe headaches since. Felt like he was lost while in his cabin. Patient was one of many cruisers sickened on the boat with Norwalk agents suspected. No testing was done by the cruise line. History of present illness. Patient has retired from the government employment as a CPA on disability due to difficulty handling numbers and performing up to pay grade. He's living on savings, long-term disability award, and a pension. Patient is accompanied by his wife, who provides the bulk of the history. Patient was last well approximately 6 years ago when he was working in the Medicare Medicaid office outside Washington, D.C. His job involved processing claims for physicians and chiropractors exceeding $1 million per day. He always received sterling job evaluations, working long hours and rarely taking vacation, but his cognitive decline created financial disasters for providers. He worked for 20 years in a small cubicle in a large room with approximately 600 other staffers with similar sized cubicles. Because of his improved job performance, he was promoted to an enclosed office shortly before the onset of the disabling illness. Patient denies any water intrusion into his home or his office, which is up as part of a recirculated air handling system separate from the rest of the building. He notes there was a history of complaints of overflowing toilets in the women's bathroom directly adjacent to a shared wall of his office. Another clue. He never saw any water. He did notice subsequently black dirt around the air return as well as the air supply vents into the room. Patient blamed his fatigue on excessive work, but was not any better with rest or his rare vacation. He later developed a slightly productive cough, worse in the morning, that he felt was due to allergies, even though the cough became year round. 6 years before presentation to his then attending, he had worsening shortness of breath. In the past, he routinely would climb 3 flights of stairs with a heavy briefcase every day to get to his cubicle. His dyspnea increased to the point where he had to take the elevator and stop bringing his briefcase to work. He noted shortness of breath walking less than a block on a level surface. He moved his bedroom from the second floor to the first floor because of fatigue, and the stairs are too much of a problem for him. He's had evaluation from pulmonology showing restrictive lung disease, for which he was told he had asthma. He never had obstructive disease. No diffusion capacity was done. Chest x-ray was normal. His cognitive issues began with difficulty handling numbers, but progressed to the trouble with recent memory, difficulty with concentration, and disorientation. After he was unable to drive home from work on several occasions, his wife wrote out directions for him to get home. He carried them with him in his car. He obtained psychiatric evaluation, was told he was developing Alzheimer's disease. No spinal tap was done, nor MRI. The antioxidant vitamins he took didn't help. Additionally, medical problems include significant cramping of his calf muscles if he extended his ankles at night. He's also noticed significant pain in the distribution of the sartorius muscle on the right side, made worse by crossing his leg to tie his shoes. He noted excessive thirst, frequent urination, which he blamed on prostate trouble. He also had frequent episodes of increased susceptibility to static shocks. He says he has amused himself by touching a doorknob in the dark to see if he could had a blue electrical discharge or a yellow one. He has seen approximately 50 physicians and spent over $150,000 out of pocket in 6 years, not counting what his health insurance paid, seeking answers for his multi-symptom illness. Patient used to be an avid birder with frequent sojourns into parks along the Chesapeake Bay area. He had multiple tick bites and occasionally had rashes, including red areas as large as a quarter. Lyme testing was normal, but he was treated for an infection with months of antibiotics, including IV doxycycline, ceftriaxone, as well as Mepron and Dapsone. Diagnoses of multiple sclerosis, chronic fatigue syndrome, fibromyalgia, depression, malingering, and combined variable immune deficiency have been entertained. He sought alternative health providers and he was diagnosed with mast cell activation syndrome. androgen imbalance, leaky gut, SIBO, and given neural retraining. Treatments have included curcumin, glutathione, ozone, hormonal manipulations, and pounds of unknown but very expensive supplements he purchased from his providers. Social history. He never smokes cigarettes or vape products. He drinks beer nearly every day after work, and an occasional glass of wine, but no stronger alcohol drinks, and used no illegal drugs. Patient's been happily married for 30 years. Although he and his wife have no children, they've had a full and active life together until his disability intervened. He enjoys outdoor sports and remains ecstatic after watching the Nationals win the World Series in 2019. 3 years ago, he went a trip to a high rise vacation condo overlooking Lake Apopka in Florida. He watched the shorebirds every day but felt worse when the wind blew in his face. Another clue. Past medical history is benign, no unusual childhood diseases. He was told that he had prediabetes 20 years ago with diagnosis disappearing when he lost 25 pounds. No medical illness other than a history of present illness, no surgeries or transfusions, no allergies. Current medications include itraconazole, oral and sublingual drops, glutathione IV, and per rectum, curcumin, charcoal clay, vitamin C, D, E, and K, Switzel, honey mixed with apple cider and nattokinase. Review of systems. Patients feel unwell on a daily basis. He admits to fatigue, feeling weak, manifested by difficulty arising from a chair after sitting. He notes low back pain and stiffness with gelling. He's had occasional headaches that are worse in the morning, possibly related to clenching his teeth. He occasionally has red eyes and blurred vision. He's had no problems with taste, smell, or swallowing. He's had a chronic cough and shortness of breath on level surfaces. He does not exercise regularly or take walks looking for birds any longer. He has shortness of breath, as mentioned, but he also has dyspnea, lifting objects up to 15 pounds. He would still try to lift more than 15 pounds. He denies exertion related chest pain, palpitations, or abnormal force of heartbeat. He's felt chest pain on several occasions, and he's passed out once, for which he's evaluated in the emergency room with no diagnosis or tests. Abdominal. Patient has water brash every morning, worse after fatty meals. No response to stomach acid remedies. Patient has frequent urination with nocturia times 3. He's not attempted any intimate activity with his wife. He notes soreness and swelling of the lower extremities, right greater than left, at the end of the day. He denies any discoloration of extremities, although his wife says his feet look plethoric. She relates a patient has decreased range of motion of his right shoulder, greater than left, with reduction of fine motor control of his fingers and his right hand, normal on left. He notes he has discomfort in his low back that has actually been improved because of his shortness of breath that prevents him from walking a full block needed to have low back and numbness in the lower extremities. He has no ongoing complaints, and um, he has no ongoing complaints of numbness. Numbness, tingling, vertigo, or ongoing discomfort in his legs, except for the cramping at night. Physical exam. Height is 6 feet, weight 185. He has some atrophy in his lower extremities at rest. Holding both outstretched hands showed tremor without tremor of head, demonstrated simply by placing a single sheet of paper on outstretched fingers. Head, eyes, ears, nose, and throat are benign. Normal chest exam, except he demonstrated post-tussic rales with a questionable increased intensity with pulmonic valve closure in S1. And S3 is present, but this finding was intermittent. He has Cheyne-Stokes respirations at the bedside. He does have a right-sided lift. Abdomen was benign. Extremities showed 2+ pitting edema on the right and 1+ on the left. Skin is dry, scaly, but not plethoric. Impression: acute GI illness superimposed on pre-existing multi-symptom illness with diffusely positive review of systems. Planned screening lab values will be done. Check Norwalk titers, follow up as indicated. Consider psych eval for PTSD. So, what are we thinking here? Is it chronic fatigue? Is it Norwalk? Is it MS? Is it chronic variable immune deficiency? Obviously, for our purposes, we're thinking probably SIRS, but what caused it? Sounds like potentially he's got several biotoxins that he's encountered. One of the hints I'll tell you is, in the Caribbean, a lot of people encounter ciguatera, which is a waterborne pathogen that's inadvertently consumed in fish and shellfish. That's probably what happened. Do we diagnose Babesia from ELISA? No. Can sarcocystitis and Eimeria do antibody test what can they do to antibody testing for babesia? False positives. What's important about thick RBC films? That's the style that we need to detect babesia, which is the intracellular parasite that goes along with tick-borne illnesses. So if we're thinking Lyme and co-infections, that's a consideration. Why is Lake Apopka important here? Well, for algae overgrowth and whether or not, when the wind blew and he was breathing in particulate matter in the air, did that worsen him as well? Would we expect to see some gray matter changes and how many are neuroquant? Several, probably. Do we have molecular hypometabolism? We'll get into that with his transcriptomics. And then what test you get from environmental labs? Well, obviously, we want to swab his home. What protocol showed prospective acquisition of this illness? So we're going to go over what he was likely exposed to. So here's findings, his objective markers. I understand our ranges are probably different, but in general, um, his white blood counts and his immune system, his standard markers, including platelets and the rest, are normal. His serum glucose is uh, high end of normal. Fungal antibodies are normal. He did show potentially a positive early antigen to the Epstein-Barr virus. Here, serum babesia is normal. We talked about, why this is probably not a great test. Mycoplasma pneumonia was normal. HSV1 and 2, CMV, varicella. Also of note, his SED rate and CRP are normal. That's typical in SIRS. So that's why it took us forever to identify proteomic markers, basically inflammatory proteins in the blood, deriving out of the innate immune system that would uncover an ongoing inflammatory process. HHV6 was normal. His thyroid was a little discordant, and you can see presence of autoimmune antibodies. That's quite typical in SIRS. I think it's actually a bellwether to some degree. If you notice, his cortisol levels were flat. So this, means that he has likely systemic inflammation. Maybe his body is trying to fend off an infection. Maybe this is from all the prior stress that he's had. But we know that this liberates the immune system overall and likely worsens his underlying condition. What about brain inflammation in particular? Well, here we have a fail of the visual test. And we know that this directly correlates to cytokine activation in the brain that leads to capillary constriction and loss of contrast capacity in the eyes. Is he genetically predisposed to SIRS? Well, we did HLA looking at chromosome 6. And when we started to put the alleles together, sure enough, he had not one, but inherited two alleles that put him at risk for a biotoxin illness. What about some of the other proteomic markers that we start to accumulate? You can see his transforming growth factor beta 1 was significantly elevated. He was quite inflamed. In addition to that, one of his Lyme markers was normal. D dimer was normal. His factor 8 was elevated, so we know he's got some clotting.